Hello everyone. I am Dr. S. Vidhyadhara Shetty, Professor, Department of Conservative Dentistry and Endodontics, Yenepoya Dental College, Yenepoya, deemed to be University. I am going to briefly talk about the endodontic emergencies, which includes specific learning objectives, definition, aims and objectives, classification, management of each emergency. Specific learning objectives, which includes to know the definition of endodontic emergency, to understand the classification of endodontic emergency, to know the management of each endodontic emergencies. By definition, endodontic emergencies are usually associated with pain and swelling and require immediate diagnosis and treatment. These emergencies are caused by pathosis in the pulpal or periradicular tissues. They also include severe traumatic injuries that result in fractures, avulsion or luxation. And it can be classified into three categories, that is before endodontic treatment, during endodontic treatment and post endodontic treatment. Before endodontic treatment, which includes dentinal pain, that is also called as hypersensitivity, pulpal pain, in that you have the acute pulpitis, that is acute irreversible pulpitis with apical periodontitis, acute periapical abscess, phoenix abscess, hot tooth, pulp necrosis, cracked tooth syndrome and traumatic injury. So, during the endodontic treatment, it can be divided again into the flare-ups and procedural errors. Flare-ups, that includes over-instrumentation due to inadequate debridement, extrusion of debris, and procedural errors, which includes sodium hypochlorite accident, air emphysema. Post-endodontic treatment, that includes high restoration, overfilling, underfilling and root fracture. So, coming to the assessment of the pain. So, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. The causative factor of inter-appointment pain comprise mechanical, chemical or microbial injury to the pulp or periradicular tissues which are induced during the root canal treatment. Coming to the acute pulpitis, it is also called as reversible pulpitis, mainly characterized by localized inflammation of the pulp, lowering the threshold stimulation for A delta nerve fibers, exaggerated non-lingering response to stimuli. Coming to the management part, removal of the cause, recontouring of the recently placed restoration which causes pain, removal of the restoration and replacing it with the sedative dressing if painful symptoms still persist following the tooth preparation, and you have to relieve the occlusion. Coming to the acute pulpitis, that is also called as irreversible pulpitis. For the diagnosis to be made, the pain must be originating from vital pulp in a tooth which is not tender to percussion. That shows that inflammation not yet reached to the periapex and is confined to the coronal pulp. If you have the minimal time, you have to do the access opening by using spoon excavator. Coronal pulp is removed, leaving behind the vital pulp tissue in the root canals. Then we have to moisten the cotton pellet with the formicrysol placed over the orifices for 1 minute, then discarded. So, new cotton pellet slightly dampened, formicrysol is placed in the chamber, sealed with the temporary restorative material, and patient is recalled later for the completion of the root canal therapy. Formicrysol, it is a caustic as long as the vital pulp tissue present between the drug, periapical tissues, and there will be no damage to the periapical tissues. Considering the time present, complete pulpectomy, that is removal of the entire pulp, ensure the patient is free from pain. Then acute pulpitis with apical periodontitis. Here, pulpal inflammation has spread to the periradicular tissue, resulting pulpal and periradicular symptoms. Here tooth is tender to percussion, heat will aggravate the pain and cold will relieve the pain. Radiographically, a small periapical radial lesion we can see, and there will be a thickening of periodontal ligament space. Coming to the treatment part, we have to relieve the occlusion. Best treatment is complete pulpectomy. And acute periapical abscess, this is nothing but it is an inflammatory process in the periradicular tissue of the teeth, often accompanied by exudate formation within the lesion. It may develop spontaneously or may follow initial endodontic treatment if bacteria are forced into the periradicular tissue. Tooth is tender to percussion, mobility will be seen, and there will be lack of vitality. So, whenever possible, acute periapical abscess should be incised and drained through the root canal space. So, there will be two methods of treating acute periapical abscess. First, you have to drain the drainage followed by antibiotic coverage, and antibiotic followed by drainage. Coming to the phoenix abscess, acute exacerbation of a chronic lesion such as cyst or granuloma, and coming to the etiology, chronic periradicular lesion such as granulomas are in state of equilibrium during which they can be completely asymptomatic. But sometimes influx of necrotic products from diseased pulp or bacteria and their toxins can cause the dormant lesion to react. This leads to the initiation of the acute inflammatory response. Coming to the symptoms, there will be a mobility of the tooth, there will be a tender to the percussion, swelling will be there, and elevation of the tooth from socket can be seen. So, coming to the treatment, same as that of the acute periapical abscess, incision and drainage. Once symptoms subsides, complete root canal treatment should be carried out. Coming to the pulp necrosis, rarely causes emergency in case if a patient notices swelling and may request for emergency treatment. The ideal treatment is complete removal of the entire necrotic pulp tissue with the proper irrigation with warm saline or sodium hypochlorite, and close dressing placed, and the patient is recalled later for the completion of endodontic treatment. Next is cracked tooth syndrome. By definition, the cracked tooth syndrome means incomplete fracture of a tooth with vital pulp. The fracture commonly involves enamel and dentin, but sometimes pulp and periodontal structure may also get involved. It is commonly seen with large and complex restoration. Coming to the diagnosis part, you have to take the proper history of the patient. There will be visual examination. You have to do the transillumination test, magnifying loops, dyes. Methylene blue can be used in the dyes. Tooth slots are more reliable. So, patient can be asked to bite on orange wood stick, rubber wheel or tooth sloth. The pain during biting or chewing, especially upon the release of pressure, is classic sign of cracked tooth syndrome. This I already explained to you guys. So, cracks in vital teeth. So, treatment for cracks not involving pulp. Compromised portion are removed and occlusal adjustment should be done, and cuspal protection should be done by using the restoration, composite, pinned amalgam cast restoration, full coverage restoration as a permanent treatment. If crack involves pulp, which causes the pulpal inflammation and necrosis, then root canal treatment is advised, followed by full coverage restoration. As a rule of thumb, if the crack involves a root canal, then you have to do the extraction. If the crack involves the pulp chamber only, then root canal treatment and restore it. Next is traumatic injuries. So, endodontic treatment may be required as a result of traumatic injury. Most common endodontic emergencies are crown fracture, root fracture and avulsion. Coming to crown fracture with vital pulp exposure, if apical closure has complete, pulp extirpation is done via the fractured opening. If apical closure has not taken place, then a formicrosal pulpotomy is done for completing apexogenesis. Radiographic evaluation done every 3 to 6 months to determine degree of apical development. Crown fracture involving necrotic pulp. Remove entire necrotic pulp tissue. If apical closure is complete, routine endodontic treatment should be carried out. If apical closure is incomplete, then you have to do the apexification. So coming to the root fracture, prognosis is depending upon the location and direction of fracture. A horizontal fracture above alveolar crest, good prognosis. Tooth, the closer the root fracture to apex is the better prognosis. So horizontal fracture at mid-root fracture below the crest of the alveolar bone, this leads to the poor prognosis, and vertical fracture of root, hopeless prognosis. So treatment is a fractured root, vital pulp and better prognosis for repair. Then next is tooth avulsion. Main causes are due to accidental cases, fall or any type of trauma. Mostly seen in anterior teeth, common in children, young adults. Instruction to be given to patient after he informs to dentist of the avulsion. Wash the tooth in running water, no brushing or cleaning, rinse the mouth, replace the tooth back into socket. If replacing is difficult, then the ideal vehicle, patient mouth as tooth bath in saliva. So other vehicles can be also used like HBSS, that is Hank's balanced salt solution, milk, saline, coconut water, if not last, clean water. On patient arrival, if tooth is in socket, you have to split the tooth, stabilize it and disocclude the replanted tooth, and if not and the tooth is brought in vehicle, then place it back into the socket. So do not attempt any endodontic treatment at this appointment and recall the patient after 1 week for the initiation of endodontic therapy. During endodontic treatment, flare-ups. By definition, an acute exacerbation of periradicular pathosis after initiation or continuation of root canal treatment. Inter-appointment flare-up is characterized by the development of pain, swelling or both following endodontic intervention. The causative factor of inter-appointment pain comprise mechanical, chemical or microbial injury to the pulp or periradicular tissues which are induced during the root canal treatment. Inadequate debridement, that is a residual pulp in the inadequately instrumented canal, undetected canals, teeth with necrotic pulps. So treatment modalities: thorough debridement of entire root canal space, removal of the entire pulp tissue with broaches and do the irrigation. Then debris extrusion, more likely to cause flare-up if pulp is necrotic and infected. The presence of an apical dentinal plug may prevent debris extrusion, over instrumentation and over obturation. But since it may harbor infectious material, the long-term prognosis is compromised. And next is over instrumentation. So incident of moderate instrumentation, then there will be a severe pain. Gross over instrumentation, which causes acute apical periodontitis producing primary inflammatory pain. In vital teeth, the apical periodontium is crushed, producing pain and inflammation. So coming to the treatment and prevention of the flare-ups, first we have to do the occlusion reduction, then you have to give the patient antibiotic prophylaxis, then incision and drainage, leaving tooth open for complete drainage for 20 minutes, then complete the removal of the pulp tissue and debris followed by closed dressing, and calcium hydroxide therapy, that is you can use it as an intracanal dressing. Then for the relieving pain, you have to give the antibiotic and analgesics. So corticosteroids for anti-inflammatory actions. Sodium hypochlorite accident. Sodium hypochlorite is the most used root canal irrigant, effective against broad spectrum of microorganisms. Symptoms of sodium hypochlorite accident: immediate severe pain, edema, ecchymosis on skin or mucosa, trismus. There will be profuse bleeding from root canal and chlorine taste or foul odor. So how to treat? First, you have to remain calm, inform to the patient. Immediate irrigate with saline to decreased soft tissue irritation. Pain can be controlled by administration of local anesthesia, acetaminophen. Narcotic analgesics are advised to relieve the pain. Then extraoral cold compresses to reduce the pain. Antibiotic coverage should be carried out for 7 days. Severe inflammation, you can use corticosteroids. Then recall the patient. So how to avoid this? Use of rubber dam, adequate access cavity preparation should be done. So needle placed between the coronal to the middle third of the root. Use of side vented needles, that is 27 gauge. Flow back of solution should be observed and slow administration of irrigant into the canal. Next is coming to the perforations. An endodontic perforation may be defined as an artificial opening in a tooth or its root created by drilling, piercing, which results in a communication between the pulp space and the periodontal tissues. Perforation lowers the prognosis of endodontic treatment. So there are the different types: access cavity perforations and root perforations. In the root perforations, we have cervical perforations, mid-root perforations and apical perforations. Causes are due to the improper access cavity preparation, improper manipulation of endodontic instruments, failure to pre-curve the instrument in curved canals, improper use of rotary instruments. Coming to the conclusion, endodontist must understand how to prevent errors, then accurately treat those teeth to which accident have occurred. The clinician must recognize the limitations in treating these difficult problems that will arise in dental practice. Active patient participation and communication must be maintained during the treatment in order to provide patients with highest quality of endodontic service. These are my references. Thank you.